I joined the group at the University of Alabama at Birmingham in 1994, and at UAB, with that acronym for that institution, they've studied congenital CMV for, well, since the mid-1960s. So for that point, 30 years, and now close to 50 years. And so I was able to join in with a group that had already done a substantial amount of work, both in the natural history of the infection, but also in the treatment. They were beginning to do the treatment trials. The phase 2 study had already been completed, and the phase 3 randomized controlled trial was underway at that particular point when I joined. So I was able to join a group that already had passion for it, and when you're around people that are passionate about things, it makes you passionate about things. I think in the United States, our biggest immediate issue in front of us comes down to whether all babies born should be screened for CMV. Management in pregnant women is, I'm a pediatrician, so it isn't something that I do on a regular basis, obviously. I think that the questions in pregnant women, unlike in Israel where there's so much screening for CMV, in the United States, ACOG, which is the American Congress on College on Obstetrics and Gynecology, they don't recommend CMV testing. So it's not as common to find a case of CMV perhaps in the United States as would be the case in Israel. In congenital CMV, sort of thinking about it from the baby side of it, from the pediatrician side of it, again, I think our main issue is whether all babies born should be screened for CMV, or whether we should do a targeted screening and only look for CMV in those babies that fail their newborn hearing screen, and those kinds of things. One of the bigger challenges with CMV in pregnancy is this relatively new finding in European studies and in studies that the group of people I collaborate with at the University of Alabama at Birmingham have done, where they have found that CMV infection can occur in a woman who had pre-existing CMV immunity. So in other words, a woman who already had antibody to CMV can be infected with a different strain of CMV, and that strain can cross the placenta, can infect the fetus, and can produce symptomatic disease in the fetus. So for me personally, the idea of testing women serologically, testing their blood for CMV antibody, is a flawed approach, because if you test negative, you're at risk of acquiring CMV. If you test positive, you're at risk for acquiring CMV. So I don't see personally that is the answer. Instead, where I think there's opportunity for advancement is the possibility of screening all babies born for congenital CMV. Now, there's questions that need to be answered there as well. There's questions about if you report to parents that their baby who looks perfectly fine and the only reason they're testing for CMV is because the system is testing for CMV that baby was born into, then you're going to have to sit down with the parents and say, look, your baby has CMV, and the overwhelming likelihood is there's not going to be any problems. The baby's not going to have any hearing loss or anything. That's the overwhelming likelihood. That's good. That's a good problem to have. But you've just introduced an uncertainty that the parents were not going to have to deal with otherwise. And that anxiety that can come from that is something that has to be understood, I think anyway, before we can just leap into a universal screening. I think we will get there. My personal view is that we will get there, and that will be where we end up, 10 years from now or something in the United States. But for right now, we're not quite there yet. If we were in a perfect world, if we were in a utopic situation, I would like to see a vaccine for CMV that prevents the infection from ever occurring in a fetus in the first place. I think that's going to be really challenging. It already has been. It's been a priority for 20 years from the World Health Organization to have a high level of need for a CMV vaccine is something that's been recognized for a long period of time. The challenge comes down to that pre-existing immunity issue. If nature does not protect a woman who has a prior CMV infection from getting a new strain of CMV, then we're having to ask the vaccine to do more than nature can do, and that's hard. Most vaccines don't do that very well. And in fact, that's what we've seen with CMV vaccines. Now, that said, there's some brilliant scientists who are continuing to work on this, and it's a high priority among pharmaceutical companies. That's wonderful. If I had my perfect world, I would like to see them succeed. I'm a pediatric infectious disease doctor, so I look at and think about how to treat babies once they're born with congenital CMV. The immediate questions in front of us are whether or not treating a baby who is completely asymptomatic. The only reason that you even know they're infected with CMV is because you've screened the population that they were born into. You've screened that population for CMV. So a really fundamental question is, would treating that group of babies, the asymptomatic babies, help? We're about to start a study just within the next couple of months that will contribute to our knowledge of that. It may not definitively prove it because of our trial design that we're having to undertake to be able to afford the trial, financially to be able to pay for it. But I think it will advance our understanding. That's one issue. I think another issue is whether starting treatment beyond the first month of age is helpful. And we have an ongoing study that we're partnering with our British colleagues on that may be informative there as well. I was struck by the conversation about termination of pregnancies even late in the course of the pregnancy. That's not a conversation we have in the United States. Things have been very controversial with abortion since the early 1970s, 1973 with the Roe versus Wade Supreme Court decision. I think a factual statement with that is that the issue was settled, if you will, in the United States by a court ruling as compared with the legislative effort. I think if it had been settled legislatively, maybe we wouldn't be continuing to have these conversations so many decades later. But we do in the United States. Maybe we were destined to anyway. Maybe abortion is just so emotional that it's never going to be fully solved, and maybe it never should be fully solved. Maybe when you're talking about the potential for life or the belief that life already exists and the soul already exists, maybe that is something that should always be debated, because we'll never know the full scope of things. We're not God. I think in the U.S. there is a reluctance to promote abortion, and I think that environment has an impact on thinking about what options are available when a fetus is infected with or impacted by congenital CMV infection. I don't know the answer. I personally believe that I never will know the answer, and I think my view on it matters less than the pregnant woman's view on it.